It is important that we acknowledge and understand the existence and impact of unconscious bias. Implicit biases are the subconscious heuristics or mental shortcuts and associations that we have for words, products, ideas, and groups of people that have been built from experience, media, society, and countless other sources. While these biases often help us cognitively navigate through the world, they can lead to unintentional prejudices. Having implicit biases about a group of people is neither wrong nor any kind of ist. Everyone has a bias of some kind. It is important, however, to be aware of your own biases so you can make sure they are not influencing your overt behavior. By the end of this module, you will be able to describe unconscious bias and explain how some unconscious bias may negatively impact health equity. We are going to begin with an old riddle. If you haven't heard this before, give yourself time to think before you respond. Here is the riddle. A father and son are in a car crash and are rushed to the hospital. The father dies. The boy is taken to the operating room and the surgeon says, "I can't operate on this boy because he is my son." To provide more background, Michaela Watman and Deborah Bell used this riddle in research. They studied the responses of two different groups, psychology students from Boston University and children from a summer camp. In both groups, they found that a minority of respondents, 14% of the college students and 15% of the children, came up with the correct answer, that the boy's mom is the surgeon. They also tried this with an alternate version of the riddle. A mother is killed, her daughter is sent to the hospital, and a nurse declines to attend to the patient because that girl is my daughter. In this case, they saw similar results. Few respondents guessed that the girl's nurse is the dad. These riddles and responses are one example of gender generalizations and biases that frequently appear in society and in healthcare. We will now discuss an article by Dr. Clarissa Kripke. You can find the full citation at the bottom of this slide. The article begins with a case scenario from a healthcare setting. In this case, the patient is a 58-year-old non-speaking male with an intellectual disability who is admitted to the hospital for cholecystitis, or swelling of the gallbladder. This patient has a past medical history that includes well-controlled seizure disorder, secondary Parkinsonism from medications, and diabetes insipidus. For this condition, surgical intervention was the best option, and the procedure was uncomplicated. Due to underlying disability and the need to drink a high volume of water to maintain a sodium balance, his recovery was slow. 6 days after surgery, he was able to swallow some medication, but still required a nasogastric tube for nutrition and hydration. At this point, the hospitalist decided to invite the hospice team to discuss goals of care. The hospice team agreed to the referral, and the patient's family was on board. However, once the patient's primary care physician began to ask more questions, it became clear that the recommendation for hospice stemmed from a misperception of the patient's quality of life and pressures to advance discharge rather than specific medical indications. Within a couple of months, the patient had returned home and was back to his previous baseline function of attending a day program and eating his favorite foods. This case study leads us to a discussion. From this example, we learned that false assumptions about a patient's quality of life can affect prognosis, the treatment options that are presented, and the referrals that we offer. As a healthcare provider, we need to actively consider that a complex disability does not equal a terminal illness, and that disability does not equal disease. Unconscious biases about disability can lead healthcare providers to make worse decisions about a patient's care. This article also provides common communication pitfalls that are seen in healthcare settings. The column on the left-hand side demonstrates things we frequently hear from healthcare providers. Statements and notes such as, "This poor unfortunate patient suffers from," or statements to patients such as, "I understand you don't want to be dependent and a burden to your family." The column on the right-hand side shows us ways that we can reframe this communication to be supportive and helpful. Those same phrases can be stated with respect, such as saying, Mr. Smith is a 56-year-old man who uses a wheelchair and volunteers as a patient advocate. He presents with, then go on to list the reason for the visit. This introduction highlights the facts and provides the reader with context to Mr. Smith's daily activities and community involvement. The second statement about being a burden can be rephrased to something like, adjusting to new functional limitations takes time. Maybe it would help if you hear directly from persons living with disabilities. This takes away the implicit bias that having a disability is a burden and that the person should feel guilt for needing accommodations or help. It also opens the door to a productive conversation. There are other helpful comparisons on this chart. Take a moment to consider language you had previously used when speaking to people with a disability. You might unconsciously state things that have subtext of abandonment or that determine a misleading prognosis. Healthcare providers frequently default to institutionalization and interventions without context when treating people with disabilities. Instead, the healthcare provider should actively think about maintaining and deepening a connection with patients with disabilities. Healthcare providers can share expertise and uncertainty in a respectful manner. Other communication pitfalls include the dehumanization of people with disabilities. Statements like, Alzheimer's disease will slowly rob your mother of her memory and dignity can be reframed to something more inclusive and helpful, like, let me share some tips on how to be a good friend or family member to a person with Alzheimer's disease. Devaluing the life of a vulnerable person by saying things like, are you sure you want the surgery and treatment even though they won't cure your disability, harbors the implicit bias that their life with disability is not worth treating. Stealing hope and disrespecting autonomy are other communication pitfalls that are led by unconscious bias towards people with disabilities. We can reframe these ideas by sharing hope and realistic planning, as well as guiding patients to supported decision-making. One last important point from this article is toward the end. You can see the selected text on the left-hand side. They state that in a study of hospitalized able-bodied patients with serious illnesses, more than 1/2 of respondents believed that some health states, such as incontinence or requiring a feeding tube, would be the same as or worse than death. However, many persons with developmental disabilities have required these supports since birth, yet still have meaningful lives. They go on to discuss that after a period of adjustment, those who live with acquired chronic illness and disability typically rate their quality of life significantly higher than their physicians and caregivers. Self-reported quality of life for persons with disabilities is not significantly different than that of the general population. To summarize, as healthcare providers, we should avoid making assumptions about patients' quality of life and avoid reinforcing patient or caregiver fears and misconceptions about living with disabilities. By being aware of unconscious biases, healthcare providers can better support all of their patients. We can improve access by reassuring all patients that we will care and advocate for them.